The American Academy of Neurology is pleased to offer today's webinar, Healthcare Equity for Neurologists. This webinar is being recorded. Evaluations for CME will be provided following the webinar in an email, and we will have a poll here to see who is joining us today. So feel free to take that as you are able to. And then I'm going to hand it over to Dr. Torres.
Thank you, Leah. It is my pleasure and privilege to introduce Dr. Bruce Ovbiagele. Today, Dr. Ovbiagele is a professor of neurology and associate dean at the University of California in San Francisco, as well as the chief of staff at the San Francisco Veterans Affairs healthcare system. Prior to these roles, he served for 6 years as professor of neurology and chair of the neurology department at the Medical University of South Carolina. His primary research involves the translation of evidence-based interventions into clinical practice and community settings to improve stroke outcomes for underserved and vulnerable populations. He currently leads several NIH-funded stroke studies in the US and Sub-Saharan Africa. He has published over 600 peer-reviewed articles in the areas of stroke prevention, epidemiology, risk factors, and outcomes, and edited 5 textbooks. And his work is has been recognized with many national and international awards. Dr. Ovbiagele has been a member of the AAN since 1998. He served on several committees and subcommittees, including the Clinical Research Training Fellowship Award Committee, the Clinical Research Subcommittee, the Minority Scholar Subcommittee, and Education Committee. He was a Neurology on the Hill participant in 2008, a Palatucci Advocacy Leadership Fellow in 2009, and Minority Scholars Visiting Professor to Morehouse School of Medicine in 2011. He has served as director of stroke courses at both the annual meeting and the fall conference, and currently directs the Health Equity for Neurologists course at the annual meeting. Finally, he has chaired the International Stroke Conference from 2016 to 2018, served as the associate editor for Stroke from 2020 to 2022, and is currently the editor-in-chief of the Journal of the American Heart Association. He is an elected member of the National Academy of Medicine and Association of American Physicians, as well as an elected fellow of the World Academy of Sciences, the World Stroke Organization, American Association for the Advancement of Science, the Royal College of Physicians in London, and the Royal Society of Public Health. That is a lot, and he has certainly done a lot. And today he is going to talk to us about healthcare equity for neurologists. Welcome, Dr. Ovbiagele.
Thank you so much, Dr. Torres, for that extremely kind introduction. And thank you to the AAN for the opportunity to do this. As you could tell from the kind rendition of some of the things I've been involved in, it's been part and parcel of the AAN supporting my career. So I'm extremely grateful to the AAN for all they've done for me. So I'll just share my screen if I may. Okay, here we go. So those are my disclosures. And by the end of this presentation, I hope that all of us will be able to adequately discuss key racial disparities in neurological outcomes, appreciate a potential link between psychosocial stressors and neurological disease, and how understudied this area of research is. Appreciate that if we're going to do anything to bridge inequities in brain health, we'll need to emphasize the social determinants of health more. I also hope we all recognize the need to diversify the subjects that we enroll in our various research studies, and also diversify our neurological workforce itself. And then finally, I hope we all have a better understanding of what the impact of leadership and advocacy could do in trying to achieve equitable brain health. So let's start off with disparities. And so forgive me, it's a broad audience, but I've decided that I should start at the very fundamentals of this topic. So we're in Black History Month, and so I put in this oft-quoted quote from the Reverend Dr. Martin Luther King, just emphasizing the issue of injustice in healthcare and how inhumane it is. So what indeed is a health disparity population? Well, it's a population for which there's a significant difference in a variety of health metrics in that population compared to the health status of the broader general population. But having said that, as many of you might be aware, oftentimes the terms health equity and health disparity are used interchangeably. But just to be clear, with health equity, we're really trying to achieve the highest level of health for everyone. What we're trying to do is to try and identify and eliminate barriers to achieving that highest level of health. So the difference between health equity and health disparities is, in one situation, in the case of equity, we're looking at differences in barriers to optimal health. And in the other situation, health disparities, we're looking at differences in actual health status. What are some common and major disparate populations? Socioeconomic disparities, racial, ethnic minorities, rural, veterans and low-income children, and also immigrants. For most of this talk, we'll be emphasizing the issue of racial and ethnic minority disparate populations. And so people of color are disproportionately affected by health disparities, including in the area of brain health. In particular, Black or African Americans are particularly susceptible to poorer neurological outcomes than their non-Hispanic white counterparts, and also many other racial and ethnic groups as well. And so this takes a look at CDC data, looking over a period of a decade, looking at age-adjusted mortality for neurological disease by race and ethnicity. And as you can see, way at the top here, and consistently so, and increasingly so, are non-Hispanic Blacks compared to their other racial and ethnic counterparts. And if you were to translate this into avertible neurological disease deaths per year, you can see that, again, comparing non-Hispanic Black Americans to non-Hispanic white Americans, there has been a big difference for a while, but you can see that trend line over time is increasing. So you come to the year 2019, and you could potentially avert almost over 3,500 neurological deaths in non-Hispanic Black Americans compared to their non-Hispanic white American counterparts. So sobering data for us to reflect upon. So having said this, the reason why we have these disparities and the reason why they fester and if not increase is because they result from very complex interactions between a whole host of different factors, going all the way from biological to the social milieu. And all of these things contribute to the disparities in care and outcomes that we eventually see in many of our patients. The Institute of Medicine, as it was called back then, now the National Academy of Medicine, over 20 years ago produced this report emphasizing unequal treatment in the United States of America. And essentially, in the first table, you see the key findings, and in the second table, you see the key recommendations. Essentially, the report confirmed that there are substantive disparities in healthcare, particularly racial and ethnic. They are associated with worse outcomes, and also they tend to occur in the context of broader historic and contemporary social and economic inequalities. Indeed, even in the context of persistent racial and ethnic discrimination. There are many sources of these disparities, but they go ahead to also point out that beyond the broader milieu, it's also been shown that many patients of racial and ethnic minority extraction are more likely to decline evidence-based treatment. And we'll go into that a little bit further later on. What did they recommend? Well, they recommended increased awareness for patients, increased awareness for providers. This particular webinar is one example of trying to do that, trying to promote consistency and equity of care using evidence-based guidelines, trying to improve cross-cultural education, and trying to do even more research to identify what the sources are for these disparities and what kind of promising interventions can we create. So as you saw from the then IOM, now the National Academy of Medicine recommendations, the issue of awareness is extremely important. So the first aspect of this is that of trust. We all know what trust means. But in terms of its manifestation, it's really a willingness to accept vulnerability or risk based on expectations, either from an organizational standpoint or from an individual standpoint. There are two levels, essentially, from the institutional and interpersonal. And oftentimes, it plays into access and quality of care as it pertains to technicality of care and also the interpersonal nature of care. There are three key factors that influence trust amongst underserved and vulnerable groups. These are patient-centeredness, the ability to be culturally competent as a provider, and also the issue of mitigating bias and stereotyping. So this is just an example of findings from one study, but which has been replicated in several studies. So this was a survey of several primary care practices in the Baltimore area. And they looked at perception of biased treatment in this particular area. They compared whites, blacks, Hispanics, and Asians. And as you can see, the minority groups were much more likely to report feeling that they were receiving biased treatment, whether you looked at blacks, Hispanics, or Asians, in terms of whether they thought they received differential care based on their race, ethnicity, whether they were treated unfairly compared to their non-white Hispanic counterparts, or even the issue of language itself. And this has been replicated in several other studies as well. Well, more recently, a survey was done by Prime, looking at patients who've experienced a stroke, breaking them down into racial and ethnic minority patients, mostly African-American or Black patients, and non-Hispanic white patients. And it's interesting, they asked, what do you feel is the biggest challenge you face in your long-term care after experiencing a stroke? And you can see all the responses here. But the biggest discrepancy in responses between these non-Hispanic, largely non-Hispanic Black patients and their non-Hispanic white counterparts was the issue of, one, mistrust of the healthcare system. You see a big difference there. And also, two, the worry about being able to work or meet responsibilities at home. A huge difference there. Otherwise, in many other cases, the differences were not big, but mistrust and those social issues after this stroke occurred. And then finally, speaking to that issue that was raised as a finding from the IOM report, which is that many racial and ethnic minorities tend to refuse evidence-based treatment. This is one most recent example, pertinent to neurology, pertinent to stroke, published in the journal Neurology last year, which showed that when you look at social demographic predictors of declining IV thrombolysis for stroke, this is from Get With The Guidelines stroke registry, you find that being non-Hispanic Black, much more likely to decline evidence-based treatment for stroke compared to their non-Hispanic white counterparts. Again, a cause for concern, right? Is this an issue of education? Is it an issue of trust? But again, something that needs to be addressed. Other issues beyond trying to mitigate bias as an individual is really trying to foster a culture within an organization to make sure that it can adequately meet the needs of a diverse group of patients. Really trying to make sure at the organizational level that the workforce in that organization closely reflects the patient population it serves, making sure that there are facilities that are amenable and convenient for the community, making sure, as you saw, this issue of a perception when there's a language barrier, making sure there's adequate language assistance. And then from an interpersonal interaction, making sure that we as providers are able to try as much as we can to bridge those cultural differences so we have an effective and sustained relationship with our patients. So there are ways to figure out, track how well you're doing when it comes to cultural and structural competence. And so you could either investigate through self-report of clinicians or staff or even leaders of your healthcare system. You could ask patients themselves and stratify that out by social demographics, or you could actually do much more objective measurements, actually doing audio or video recordings. And the great news is that this systematic review showed that a majority of interventions have been shown to be effective at really increasing patient knowledge, improving access, and enhancing clinician cultural competence. So these were all interventions that were designed to be culturally targeted at improving these measures of patient knowledge and access. And you can see some of the characteristics of these beneficial interventions where they tapped into the community members' expertise. They made sure that they involved screening programs and lay educators and patient advocates. And they also made sure that they leaned on the contributions of nurses and counselors and community health workers to really make sure that that information, which was culturally tailored, was adequately delivered. So we spoke about the issue of the social determinants of health. These are those entities in which we all are born into, we live in, or we go to work in, but they have a huge impact on our health status. There are 6 identified social determinants of health, all listed in the different columns here. Many times, of course, and rightly so, providers ask, well, how am I going to have an impact on employment and income? And rightly so. Many times when it comes to the issue of social determinants, we focus on this very last column, the column of the healthcare system, in which we focus on the issue of coverage and cultural competence, which we just spoke about, and of course, quality of care. But more and more, we're recognizing that we as providers need to be more involved in this 5th column, the issue of the community and social context. How well are we involved in integrating the social milieu into the care plans we develop for our patients? How much do we know about the support systems for our patients once they leave our offices? How involved are we in engaging the community? What are we doing in terms of this issue of perceived discrimination? What about the broader societal psychosocial stress many patients of color experience? And so let's talk about psychosocial stress. Well, we know lots of evidence showing that it has an impact on several diseases, including neurological diseases. We know that it can impair cognitive functioning. We know that it can predispose individuals to more mental health problems. We know that it also varies based on the type of stressor, how long individuals are exposed to that stress, and also what the social environment of that particularly stressed individual actually is, when the stress occurs, and of course that person's own genetic predisposition. One of the things that is being increasingly recognized is how much psychosocial stress might be playing into some of the disparities we see in disease, and including neurological disease. And so increasingly, we are seeing practitioners actually use scales like this, the everyday discrimination scale and the heightened vigilance scale, putting it in their waiting rooms while their patients wait for them, trying to really decipher if patients are experiencing substantial psychosocial stress from the outside that might be impacting their ability to either adhere to the medical regimen or to have better outcomes. And one interesting area of focus is that of the allostatic load. And so this essentially represents a summary index of multi-system risk. It has 3 main categories: cardiovascular, metabolic, and immune. Metabolic and immune have especially been shown or suggested to potentially play into some of the disparities that we see in racial and ethnic outcomes. And so it's been thought that there's a link between the psychosocial stress and this measure of allostatic load. And it's thought that in particular, metabolic processes might be the strongest predictor of allostatic load for adults. Now you take a look at allostatic load by age and race. And at whatever age you look at, when you look at allostatic load comparing whites, non-Hispanic whites and blacks, whether it's 18 to 24 going all the way to 55 to 64, blacks on average have a higher mean score of allostatic load compared to their non-Hispanic white counterparts. And you can see it starts rather early and it stays the same all the way. So at baseline, there's a higher allostatic load, and it's likely contributing to the disparities that we see. So we've spoken about the definitions, we've spoken about awareness. What do we do about the community? And so it's clear that the community has to receive increasing focus if we are really going to try and address disparities in neurological disease. So what's the goal? The goal really is to try and promote ideal and optimal functioning in the patient's home and neighborhood or their chosen environment. So beyond your office, making sure that the milieu the patient spends most of their time with is ideal for facilitating their optimal health. And there are many ways one can try and do this through nurse care managers, community health workers, but essentially you're trying to use the community to try and improve care. And so many have said it's imperative that healthcare systems, organizations, units, departments, and programs have viable and sustainable partnerships with the communities that they serve. And that it would be helpful to provide a forum for both community members and academicians, community members and clinicians to talk about research being done or to talk about the needs of the community and figure out ways in which they can help each other and improve the overall health of the community. Many organizations are increasingly creating these community advisory boards which compose lay community members, religious leaders, care providers, advocates in communities, and even legislative representatives. Again, it's really trying to tap into the wisdom of the community to improve the health of the community. One big example is the Bay Area Regional Health Inequities Initiative, organizational and assessment. And it's a way of really trying to assess what your organization can potentially do to try and improve its collaboration with the community in order to improve outcomes for that community. It's especially helpful for communities in which you have vulnerable and underserved communities, really making sure that there's a good collaboration. There is community accessible data and planning. You are integrating the social, environmental, and structural determinants of health. And again, this issue of cultural sensitivity by individual providers and then the organization as a whole is extremely important. So if you're like me and you have an interest or have studied health disparities, sometimes it can get a little bit discouraging because while fortunately we are finding better treatments for neurological disease, what you find is that the disparities themselves, especially racial ethnic disparities, are not getting necessarily any better or smaller or disappearing. But this is one encouraging example from end-stage renal disease amongst diabetics. And I put it in because of the way they use the community to try and improve care. So it's been known for a long while that for Native Americans, they had much higher incidence of end-stage renal disease compared to their non-Hispanic white counterparts and Asian counterparts. Here they are in orange, I beg your pardon. And you can see non-Hispanic whites here, you can see Asians here, you can see that Blacks or African Americans are still way up here. But you see this big difference. You actually see the curve being bent and the disparity being closed over time. So this is one of the few high-profile examples where you had a clear disparity and you saw that disparity gradually lessen over time to the point that much more recently now there is no disparity for this particular disease entity in this particular population compared to non-Hispanic whites. A very encouraging and impressive example. What did they do? Well, there was no unique intervention, disappointingly. It was really but on the other hand, maybe encouragingly, because what they did was really reorganize the existing healthcare system and make sure there was much better implementation of proven interventions. They focused not just on short-term outcomes, but they really looked to make sure that the outcomes were sustainable. They looked at issues of cost, issues of wellness of the entire community. And you can see here a big part of what they did in reorganizing the system was really to do much more community outreach. Again, this issue of cultural sensitivity, this issue of having people extended into the community, making sure you track things and improve things, all led to many of these evidence-based measures being improved. And that's why you saw that drop in the incidence of end-stage renal disease. So it's a community healthcare system partnership that leads to improved outcomes and an elimination, in this case, of a well-established disparity. What are some promising community partnership initiatives out there? They are not necessarily focused just on neurological disease, but I do think that they are instructive. So one here is a barbershop-based health support intervention. It's called the CUT Hypertension Program, developed at Cedars-Sinai Health, where a pharmacist works virtually to beat hypertension in clients who receive health coaching at barbershops. So that's one. Another one is a partnership with Native American tribes are really trying to create an infrastructure for a biobank for indigenous people. Another one is a situation where with the community, they're providing weekly batches of fresh vegetables to patients who are at risk for at least one chronic disease, including many risk factors for stroke as well, and their health is monitored over time. But essentially showing partnerships between healthcare systems and the community trying to improve health for that particular population. And so the National Academy of Science, Engineering, and Medicine in just about 4 years ago came out with a new report about integrating social care into the delivery of care. And essentially what they said was that it should be guided by awareness, adjustment, assistance, alignment, and advocacy. And then we all need to work to build the appropriate workforce to integrate social care into healthcare delivery. Now, ideally, of course, every member of the interprofessional care team should have some baseline understanding of social care. But really what they recommended was that these professionals should be front and center in trying to better integrate social care into the delivery of healthcare. So in the United Kingdom, they have this entity called social prescribing, and it's gaining momentum. And it's really focused on patients with chronic medical conditions, including many of our patients who unfortunately experience neurological diseases. And the whole idea here is not that a provider becomes a social worker, but it's really trying to change the expectations of our patients and even of ourselves, that it's just a question of a drug or a device that's going to solve the patient's problem, and really recognizing that there are broader issues out there and that the physicians or the providers should be aware of what social interventions, what local resources might be available to try and improve that patient's care. It's been shown that social prescribing can reduce care utilization, ED visits, and even improve health outcomes. And really, it's about trying to have that conversation. Now, I know we're all pressed for time when we have encounters. Maybe patients can fill out questionnaires before they come in. But really, it's trying to change the mindset, recognizing that, of course, medications and devices help, but also recognizing that there's a broader world out there that has a huge impact on how well our patients will do health-wise, and we, as their carers, need to tap into it. So what about the workforce? As you saw, that was part of the IOM recommendation. So this is the 3D framework. And what it posits is that in order to address health disparities and incorporate social determinants to address those health disparities, you really have to diversify the workforce. What does doing that do? Well, it results in higher patient satisfaction and trust, enhances cultural competency, improves access, and even improves our ability to recruit underrepresented populations into our research studies. So just give you an example, a snapshot, a very busy slide, but a snapshot of the different key medical disciplines compared to the US population. As you can see, when you look at APRNs, for instance, just 5.2% are Black or African American, physicians 5.3%. If you look at Hispanics, 4.4% APRNs and 6%, again, compared to their numbers in the US population itself. And so it's been shown that racial diversity has many, many benefits, but it's also been shown that the more trainees, the more you can diversify the workforce, the more likely you are to get a workforce committed to trying to address the issue of disparities. People who enroll in med school who are of racial and ethnic minority extraction are much more likely to want to leave med school with the intent of serving the underserved. And so it's very important. They're much more likely to want to engage in research to address disparities. They're much more likely to want to contribute to mentoring people who are like them and from similar backgrounds. So again, it's an investment that's likely to pay substantial dividend in a variety of areas. And so looking at neurology itself, again, the US population, and then looking at US neurologists, 4.2% US population Blacks, 3.2 US neurologists. So even lower than the proportion of physicians in the country. As we saw, for physicians, it's about 5%. So we as neurologists, we lag in that diversity. It's a similar story when it comes to US neurologists who are of Hispanic or Latinx extraction as well. As Marian Wright Elderman said, you can't be what you can't see. So again, just underscoring the avenue for us to improve. So we've been working with the American Academy of Neurology to try and diversify the academic neurology workforce. This is the Transcends program. And what we do is to expose individuals who are from underrepresented in medicine backgrounds to a 2-year curriculum in which they receive a Master of Science in Clinical Research degree, lots of AAN annual meeting activities. They are matched with mentors. And the whole idea is to build that research workforce out. We are grateful that this program is funded both by NINDS and the AAN. We have another partnership that's ongoing as well. In fact, we just did the 4th edition of this last week at the International Stroke Conference. And this is our Heads Up Conference. This is really focused on disparities. But what we've done is not just to focus on the science, but also focus on building the pipeline of early career investigators. And so what you see here are Travel Scholar awardees. Again, this is funded by NINDS and the American Stroke Association, who have been supported to present their work and receive mentoring and feedback during the conference. There are also many opportunities for networking and many sessions which are focused on early career development activities. These individuals are, many of them are from underrepresented groups, but not necessarily. It's really trying to build that workforce who is interested and capable of addressing disparities in stroke. And so what are some things that could be done at both the individual, the department, or the association level? So for an individual, being cognizant of biases, trying to slow down and focus when one is engaging in care, trying to get to personally know more members of your team who are either different or underrepresented. From the Department of Practice side, really trying to incorporate a diversity, inclusion, and equity into your core mission and your leadership. Having more committees that are diverse, trying to promote counter-stereotypical images. From an association standpoint, things like what the AAN is doing here in supporting some of the programs I just mentioned, and also in terms of trying to have dashboards or scorecards to nudge people forward and trying to make sure that the composition of committees at the association level is diverse. So we've spoken about definitions, we've spoken about awareness, we've spoken about the community, we've spoken about the workforce. Well, what about academics? Well, in recent history, what we know is that initially, from the late 60s, there were affirmative action programs to try and increase minority enrollment in medical schools. And there was a high point in 1975, where by that point, underrepresented minorities constituted 10%, up to 10% of the medical school classes. They stayed that way for a while, and then they started to dip again. Both the AAMC, the American Association for Medical Colleges, and the Sullivan Commission on Diversity raised the alarm about this issue and said that one of the ways to try and ensure that the workforce is more diverse is to make sure that there's diversity of academic medical leaders. As we saw from the other slide, you can't be what you can't see. What about education itself? Well, the World Health Organization notes that when you look at a given patient's health, at least half of the contributing factors are not related to biology at all. It's really related to those social determinants of health. Yet, in many curricula, you find that trainees are only learning about 50% of the health because they're focusing primarily on biology. And as such, they might be missing a huge opportunity. So for our neurology resident curriculum, for our curricula for our subspecialty fellowships in neurology, how much are our trainees learning about the contributors beyond biology to the diseases and disparities that they see? And some examples are listed here about the issue of asthma and its predominance in communities of color, and the issue of hypertension, the physiologic basis versus the contributors from environmental and social stress. But the moral of this story is we could potentially do even more in imparting knowledge about the contributions of the social determinants of health to disparities in neurological disease. And again, more of the same in just showing how underrepresented certain race ethnic groups are in biomedical research. And as I mentioned, after going up from this in the middle 70s, it was flat. And then since the 1990s, there has been a drop in the number, in particular, of Black medical students Black students in medical schools. So again, we saw things go up, they started going precipitously down, and that needs to be addressed. In terms of research funding, not where it could be, there has been improvement over time, slightly. For instance, this example of 2013 to 2018 for Career Development Awards, and the same thing for R01 grants. But nonetheless, for career development grants at the NIH, just 5.5% for Blacks, for Hispanics, 6.5%. For R01, these independent grants, 2% for Blacks and 4%. Again, when you compare to the general population, there is room for improvement. And so we leave research alone and we talk about actually academic faculty itself. We look at the important pipeline of assistant professors and associate professors. And you look over time from 1990 to 2015. The good news here is that these curves represent underrepresentativeness. So it's a little bit counterintuitive, but the curves represent, and so here you see this curve are non-Hispanic white women for assistant professors. There has been a decrease in the underrepresentativeness of assistant professors, and that should be celebrated. That's wonderful. But you can see for many of these other curves, red and purple or so, which represent racial and ethnic minorities, there's been an increase in the underrepresentation of assistant professors. You see the same things for associate professors as well. In fact, here you see a more precipitous drop in the underrepresentation of non-Hispanic white women who are associate professors, which is fantastic. But you see again this ticking up of the underrepresentativeness of the racial and ethnic minority groups as well. So whether you look at medical students, whether you look at funding, whether you look at academic faculty, things are not necessarily going in the right direction. So we really need to, we've spoken about diversity of the workforce. What about the research subjects, the research participants, our patients who we try to recruit into many of the important studies that we do? Well, unfortunately, when you look again at the US population, when it comes to trial participants, for Blacks, they just make up about 5% of trial participants. For Hispanics and Latinos, even worse, less than 1% of trial participants. And so there's clearly a lack of representation from these racial and ethnic minority groups in these clinical trials. And unfortunately, what that does is that it doesn't allow some of these interventions to be properly translated into real world use. And so some of these interventions may not necessarily be as efficacious for these disparate populations. And so we really need to do something to try and improve the recruitment of these racial and ethnic minority groups into the important studies that we do in neurology. Just an example of the CREST study, a landmark study published in the New England Journal of Medicine, looking at 2 different types of carotid revascularization. And you look at the proportion of Blacks who were enrolled in the study, Blacks, remember, who are disproportionately affected by stroke, you see just 4.4%. And for Hispanic patients, 3.6%, remember, compared to their proportion in the US population. And we're actually even fortunate that for NIH-funded studies, NIH requires that these racial and ethnic categories be presented. In many global neurological studies, you don't have that requirement necessarily. Many industry-funded studies, you don't have that requirement. So it's even harder to decipher the proportion of racial and ethnic minority participants in those type of either global studies or industry-funded studies. Again, something that we could potentially address. So what does one do to try and get more research subjects of racial and ethnic minority extraction? I took this from a wonderful presentation and paper by Phil Gorelick, who has a lot of expertise and experience in really doing studies in underrepresented populations. And as he said in his paper and his presentation, you go to the patient. You have to invest in the long game. You have to build trust, as we mentioned before, but you really have to go to the patient. Avoid tokenism, try and make sure you reach out to the community. But really, we go back to that issue of creating meaningful partnerships between the health system organizations and the community. It's extremely important for clinical care. It's extremely important if you are going to recruit more underrepresented folks into your studies. One aspect of doing that is community-based participatory research, which recognizes the community as its unit of identity and really tries to facilitate collaborative partnerships at all phases of research. It's always a cyclical and iterative process, but the whole idea, again, is to try and make sure that what you're doing is of high relevance to the community that you intend or you are serving. So finally, we'll talk about the issue of policy. And so I put in this slide here quotes from 2020 by the congressional TRI-CAUCUS leaders. And essentially, all of them said the same thing in different ways, saying that COVID-19 really exposed the inequities in health within our society. It's a wake-up call. It's brought the disparity to light. These disparities have been even worse. It's placed the issue right at the forefront. But you see, whether it's the Congressional Hispanic Caucus, the Asian Pacific American Caucus, or the Congressional Black Caucus, again, these leaders are recognizing that COVID-19 opened up our eyes, and it's about time we took this issue even more seriously than we were before. And so what are avenues to try and use policy to address healthcare disparities? There's the issue of expanding access and health insurance, of course, public health strategies, better coordination of care, as we saw in that Native American end-stage renal disease in diabetic initiative, more patient-centered care, and making sure that one tracks what one is doing. And just an example of the Affordable Care Act and its impact broken down by white, Black, or Hispanic over the first 6 years. Over its nearly first 6 years in terms of just insurance coverage. And you can see the act was passed around here, but you can see in no short order, you begin to see a dipping in terms of insurance coverage by race, ethnicity, and the biggest benefit really was for Hispanic patients, followed by Black patients, and then white patients. But really, the act itself had an impact in trying to really improve the proportion of those who are covered, presumably would help them to have better outcomes. And that particular Affordable Care Act has provisions in it which are aimed at reducing or eliminating health disparities. And so there's a workforce diversity component to it. There's actually a cultural competence training education component to it. And there are resources that have been put in it to fund health disparities research as well. And PCORI, of course, many of you are familiar with, came as a result of the ACA. Some of the things going back to 2020 when inequities in health and health disparities came much more to the fore. Many states, whether it was from the health department or the governor's office or the attorney general's office, did things to try and shine a greater light on the issue of health equity. And you can see many of the states listed here. This is not exhaustive, but I just put in a few highlights that there are more dashboards going on, trying to see what's going on, trying to create justice task forces, trying to use telehealth more to try and overcome disparities, trying to tease out and address social determinants of health. Again, this issue of having it on board. So really what you see in terms of what is being done, there's surveillance going on. There are groups that have been created or assembled to monitor and address the issue. And there are tools being used in the form of telehealth or in the form of other ways to try and address the issue of the social determinants of health. Very encouragingly, in January of last year, the Clinical Treatment Act law went into effect. As many of you might have known, Medicaid previously was the only major payer that was not required by federal law to provide coverage for the routine cost of participation in a clinical trial. As many of you know, of course, Medicare covers over 42 million beneficiaries, many of whom, most of whom are people of underrepresented minority, racial and ethnic minority extraction. And so having this law, which now allows and permits Medicaid to now cover routine patient costs for clinical trials, would hopefully allow more racial and ethnic minority patients to be enrolled in clinical trials without that barrier being in place. Again, remember, equity is about trying to remove barriers And so this hopefully will remove many barriers to participation for people of racial and ethnic minority extraction. Very intriguingly, this is the Health Equity and Accountability Act. Lest you get too excited, this act has not passed, even though it's been introduced in every Congress since 2007. It's really aimed at a whole host of different disparate populations, looking at racial ethnic minorities, rural populations, socioeconomically disadvantaged. And there's so many wonderful things this particular legislation would do. It's not been passed yet. It's probably going to be introduced again, I think. Probably not going to pass again, but hopefully at some point, this act might pass and might also be another big help in trying to bridge disparities across the board and including for neurological outcomes as well. What agencies typically are focused on addressing health inequities in the US? The National Institute of Minority Health and Health Disparities, one major institute which has that as its mission, but the entire NIH is increasingly have that as its mission. And as I mentioned, NINDS, the Neurological Institute, has been very supportive and has invested a lot to try and address the issue of health disparities. But others are, of course, Office of Minority Health, the Office of Minority Health and Health Disparities, the Office of Behavioral Health Equity, and also the Office of Health Equity. So you have a lot of agencies throughout the federal government which are tasked with addressing health inequities in the United States. And so, again, we recognize that when it comes to addressing health disparities, one has to address health inequities. One has to remove those barriers to optimal health in order to eliminate the disparities in health status. And so it's important to engage system stakeholders, and there are key principles that have, or best practices that have been mentioned. It's very important to try and build relationships. I've been privileged to go to Neurology on the Hill twice, and I was part of the Participatory Advocacy Forum as well, in which I learned quite a bit, but realized that as we, of course, administer care to our disparate populations, another tool in our toolkit, so to speak, is to try and better engage stakeholders within our system, the leaders in our healthcare system, but also policymakers at large, to try and make sure that we get them involved in removing these barriers to optimal neurological health for all communities. So I will summarize at this point. So there are several established health inequities and certainly health disparities for patients who have or are at risk for neurological diseases. We know that there are several potential targets at the levels of the patient, the provider, the system, and the community that we could avail ourselves of. We know that unfortunately there have been relatively few interventions that have really aimed at many of the issues that we have already discussed: communication, bias, stereotyping, and the important social determinants of health. We need more studies to be done. There are ongoing programs like Transcends and Heads Up, trying to broaden the number of individuals of underrepresented extraction who are engaged in research and academia, but we need to do more. And then finally, we know that lots of things are going on at the legislative and executive level. We need more neurologists advocating for policy that will improve health for all neurological populations, particularly these disparate ones. And of course, we can play a role in doing advocacy in that regard. I leave you with this very last quote from Kathleen Sebelius. She was the former Secretary of Health and Human Services. She was also the former governor of Kansas. And as she said, at the time when the Affordable Care Act was passed, it's time to refocus, to reinforce and repeat the message that health disparities exist, and that the benefits of them, and I'm paraphrasing here, don't just benefit the disparate populations, but they benefit everyone. Thank you very much for your kind audience, and I look forward to any questions or comments in the intervening time. Thank you.
All right, if anyone has any questions, please feel free to post them in our question and answer section, and I'm happy to read them out and get them answered. But I guess in the meantime, Dr. Ovbiagele. For our younger audience, you've obviously accomplished a lot in your career. How can they get started and get started with work like this that's basically impacting the problems that we're seeing in our communities? Because usually I feel like in life in general, inertia is one of the biggest obstacles. So how do we overcome that and start continuing the work that you've been doing?
No, thank you so much. First of all, when you said younger audience, you made me feel very old, but I'll not take offense at that, Dr. Torres. Yeah, no, absolutely. I think that's a very important question. And how do you get started? Well, I always believe that it's best to start off with the issues that bother you the most. The reason why is because it's those issues for which you'll have the most energy to apply yourself. Apply yourself through the no's you'll get from either your leaders, the no's you might get from editors, the no's you might get from funding agencies, and also because it almost always feeds upon itself. So whether that issue or that problem is something that's staring you in the face, if it's something that's a little bit further off, try first of all to find out what that problem is that bothers you the most, resonates with you most, and start to focus on that. Now, sometimes that problem might be huge, and you might need to break it into little bits, or sometimes it might be small. I believe in starting small. So whether the problem is small and you just start with that small problem, or the problem is big and you decide to take little bits of it, it's almost always important to start small and to get wins along the way. They encourage you, but they also send a signal to other people that, oh, this is worthwhile investing in. This is worthwhile supporting. So I think that's a way to do it. It's extremely important to have a mentor. It is, and by mentor, I mean mentor and also sponsor. It's almost imperative. And people say, well, how do I get a mentor? I see that person I admire over there. How do I get that person? Well, there are many avenues to do that. Now, of course, many of the successful people are busy and they're already mentoring lots of people. And so you may want to see how you can best approach them, but make the mentoring for them as easy as possible. I've been privileged to mentor people who've approached me, even though my bandwidth is wide, because they made it really easy for me. It wasn't a situation they would, they weren't expecting to be spoon-fed, not because they don't deserve to be spoon-fed, but they recognize that I don't have the bandwidth. And in those situations were a joy to have, because they would remind me, they would, even sometimes when I wouldn't respond to emails, they were patient enough not to take it personally and then come back again. That helped me a lot. That patience, that accommodation, that proactiveness helped me a lot. And then the other thing is, and I say this not just because this is supported by the AAN, but being involved with your professional associations is imperative. As you mentioned, Dr. Torres, I've been part of the AAN since 1998 while I was a resident, and it's been supporting my career every step of the way. So whatever problem you identify, try and see if there is an AAN committee, subcommittee, task force to which you can partner and help you to address that particular issue. Thanks.
You make some excellent points. About the AAN, I've been lucky enough to be in one of their leadership programs, and there are many programs that the AAN has to help people that are starting their careers to really engage their communities, engage whether it's research or whether it's advocacy. There are a lot of programs out there. All it takes is applying for them and getting started. And you make another good point in terms of mentoring, that people see mentoring as a one-way street. The mentor teaches the mentee, but it really should be a communication, and it should be a two-way street where the mentee maybe proposes a project and the mentor helps out with the project or gives pointers. So it really, it's that conversation that allows us to be more effective mentors, actually, and to also be able to take on more mentees. And so those are great pieces of advice. Another question that I had, and I agree 100% with you, that with problems like this, really engaging as many stakeholders as possible, community leaders as possible, leads to more effective interventions. But again, that's another potential obstacle that needs to be crossed. What strategies do you usually use when trying to bring stakeholders to the table and engage them in the work that you're doing?
Yeah, no, thank you for that as well. And it's important. So there is no silver bullet. There's no magic formula. The issue is trying to be as respectful and as culturally aware as possible. If there were two things I would say, it's respect and humility, because I've been privileged to work in different populations, whether it is a population serving a low-income immigrant population to rural South, to now where I am in a veterans population. And in each situation, I think the best way to wade into that population was with tremendous humility and respect. People appreciate that. People welcome anyone who wants to go above and beyond to reach out to them to get their perspective. The truth of the matter is that we don't do it enough. I don't even do it enough, but we should do more and more of it. It can be humbling, it can be intimidating sometimes. You don't want to make a mistake, but I can assure you that if it's done with that spirit of humility and respect, it is almost always reciprocated, because many of these communities are also clutching at straws. They're looking for solutions. They look at the academy, the ivory tower there, and they're also intimidated. We're intimidated, they're intimidated. But somebody has to make the first step. And more than often than not, it has to be us, because we are kind of a little bit on the, and so we have to make that step. But it's extremely important to do that. If you have members of your workforce who are part of that community, it helps a great deal. 1/3 of our workforce here at the VA are veterans themselves. And that's how I use to get into the community. So it's one way to try and get in the community is to work with workforce members who are of that community. Thanks.
And one last question. This is from the audience. Obviously, one of the ways to reduce distrust in medical care is to have practitioners that look like their patients and are as diverse as their patients. Do you have any ideas or thoughts on how institutions can improve the diversity of their staff so that we can break down some of those barriers and increase the trust that the community has in their hospital systems and their institutions?
Yeah, no, again, it's a tough problem, and it's tough not just because there are so few, so everybody's trying to get those few, but I do think that the symbolism of leadership that is diverse is always very, very helpful. The symbolism of what is highlighted, whether it's on a website, whether it's in a brochure, whether it's all very, because these are signals that you send. I'm originally from Nigeria. I say this all the time. When I first came to this country, I said, oh, where have they taken Nigerians before? That's the first place, because that's how where are they Nigerian friendly? And those are the things, because again, there's that level of intimidation. So to every extent that an organization, a system, a department can make its image one that looks inclusive, it's extremely attractive to people. Extremely attractive. It's one thing to look inclusive, nothing to actually when people get there to be inclusive. So that's the other part that's important. But to actually get them in, it's very important. Those symbols are very important. Thank you.
And it is 5 o'clock, so I think we'll stop with questions there. But thank you again for your amazing talk and for joining us today. And thanks everyone for joining. And we hope everyone has an amazing day.
Thank you. Thank you so much. Bye-bye, everyone. Bye.